We are going to hear from our professor, Dr. Rasha Odeh. Professor Rasha is a pediatric endocrinologist at the University Hospital, مستشفى الجامعة الأردنية، كلية الطب الجامعة الأردنية الأردن. And she is very well-known pediatric endocrinologist, and she has worked very well in the field of diabetology in Jordan and in the MENA region. She is one of the members of the Pediatric Arab Association.
Thank you
Dr.
very
Rasha,
much.
the floor is yours.
Thank you, Nadima, for the kind introduction. First, I would like to thank the organizing committee for having me today. Shukran, Dr. Misbah. I enjoyed the lovely city of Luxor today morning. Very beautiful city with very beautiful people. Thank you for staying late also. So today, now I'm going to talk about another type of diabetes, type 1 diabetes. And I was given the task to talk about endotypes of type 1 diabetes. Does anybody know what is the concept, or anybody has heard about this before? If yes, please just raise your hand. Okay, that's good. So I hope I can today explain what is the concept behind the endotypes of type 1 diabetes, and I'm going to talk about the proposed endotypes and their clinical relevance. And when I talk proposed, because they are not yet there, we are talking about the development of the endotypes. As Dr. Sayed has spoken in the previous session, diabetes is a heterogeneous disease. It has many, many classifications. And all these classifications are for the reason of having the right treatment for the right person at the right time. That's what we call precision medicine. And until now, or until recently, the type 1 diabetes is only looked at as an autoimmune disease, and that's it. And the only treatment is insulin. But what is going on is that we are seeing another way of thinking about type 1 diabetes. And the idea of endotyping the diseases came from diseases like asthma, that in the 1990s, they looked at the response of IgE treatment for people with hyper-responsiveness in the airways and wheezes and so on. And they saw that their response to the anti-IgE treatment is very different, although they are all having the same symptoms of asthma. And they looked at, is this a manifestation that these people with symptoms of asthma have different mechanisms of asthma, and they changed their way of looking at asthma from only symptoms or phenotypes into mechanistic ways that are leading to the symptoms of asthma, and they came up with different endotypes of asthma with precision treatments. So how can we apply this to type 1 diabetes? Now, type 1 diabetes endotype is supposed to be a subtype of type 1 diabetes that can be defined by a distinct functional or pathobiological mechanism that is therapeutically tractable. So I need three things. I need subtype, I need different or distinct pathophysiology, and I need a treatment for this pathophysiology. This is still highly debated. Does it really exist? Or is it something that we are trying to do or to invent? Why is that? It's difficult to look into the pancreatic tissue at the time of diagnosis. This is an organ that we do not have access for the tissues for that organ. We don't know yet the whole autoimmune process that is going on. And when we want to test certain medications, the population that we are talking about are children and adolescents, and having testing on them new treatments is not as easy as in adults. On the other hand, I have a lot of evidence that there is a heterogeneous background in type 1 diabetes. First of all, we have diabetes type 1 in all age groups. Why does this person develop it at 2, 3, 4 years old, and the other one at 40, 50 years old? Then we have the genetic susceptibility that is complex. The rate of progression. You have type 1s that they progress very dramatically fast, and other ones that they have insulin secretory capacity for a long time. The complication rate, the glycemic control, and the therapeutic intervention all are heterogeneous in patients with type 1. We don't see the same in all patients with type 1. So I'm going to talk about this heterogeneity in order to come up with the idea of the endotype. Now, there is this model of the stages of type 1 diabetes. It starts with having a normal beta cell mass. You have a genetic predisposition with environmental factors. Then you have an autoimmune process starting. You develop autoantibodies. Stage 1, when you have 2 antibodies with normal glucose. Stage 2, when you have several autoantibodies with dysglycemia, and stage 3 when you have more than 2 autoantibodies with clinical diabetes, and this is where we start insulin. And we know from studies that if a person develops 2 or more autoantibodies, it's evident that they will develop type 1 diabetes. They will develop hyperglycemia. But the difference is when. So if you have 2 antibodies, will you develop it in 5 years, 10 years, 15 years? And here we start seeing the first difference that is judged by age. So if you develop 2 or more antibodies as a child, you will more probably get diabetes very early than if you develop these 2 antibodies as an adult. As you can see, the black and green lines show you when you develop 2 or more antibodies and how fast you go into diabetes. Whereas the red line shows you that when you are in an adult. Another thing is that how fast you lose your insulin secretory capacity. And this is also seen, there's a difference in adults and pediatric age group. So children will lose their capacity to secrete insulin very fast. But is it the age itself or what the age is representing? So the age may be a proxy of what's going on the immune level. This is just a notion to know that also sex has a time-dependent impact on diabetes risk. So before puberty, we know there's male to female ratio is the same. But against expected after the age of puberty, type 1 diabetes is more common in males than females, against what we might expect that autoimmunity is more in females. So there might be a problem in the beta cells themselves, not the autoimmune system. So what are the mechanistic differences that also have been shown? Now, we have many studies now that are looking into persons who are at risk of type 1 diabetes, and they are followed since birth until they get the autoantibodies. And they saw 2 distinct different types. The ones who are developing the GAD antibodies first are the older ones who have HLA-DR3 and who have a more slow process, so to say. Whereas the ones who develop the insulin autoantibody, the orange one, they develop the seroconversion at an early age. They progress into multiple autoantibodies faster. They carry more the HLA-DR4. And these are the ones who are progressing to type 1 diabetes earlier. So what's going on? Why is there a difference between the ones who's developing this kind of antibody and the other who's developing the other? So another major difference that has been also elucidated is that, as we mentioned, it's not easy that we have tissues from the pancreas at the time of diagnosis. And now there are many collaborative work that is being done by different centers that have access to this tissue. And they are looking at different immune staining. What were the cells that were involved in the autoimmune process at diagnosis? And here also they saw 2 distinct populations. Children who are below 7 years of age showed an extensive inflammatory process in their immune cells, involving, as you can see in the upper panel, B cells, T cells, And if you can see the CD8, that is the cytotoxic T cells. And here you lose the capacity to produce insulin very fast. Whereas the ones who develop diabetes after the age of 13 years, as you can see in the middle panel, they have no B cells. The CD8 cells are there, but they are less, and they progress a little bit slower. And if you look at the adult pancreata, there are much fewer CD8 cytotoxic T cells to cause the issue, the destruction, but they have a lot of T regulatory T cells that are protective. So we have two also different immune markers in different age groups. And if you look at the immune staining, the one on the right side, or your left, sorry, راحت الصورة. So the ones with the green and the blue is the ones with dots الحمراء, the red ones. These are the lymphocytes, and the ones that are showing that they have few lymphocytes are the older age. Whereas, but the older one, it's in the periphery. It's much less of an immune attack. When you look at the ones who are young age, you look at the dots, the red dots, they are very, very extensive, invading the islets, and the islet itself the architecture is destroyed. So there is an aggressive autoimmune process happening in younger ages. Another thing that in younger age group, they showed in these histopathological staining what we call aberrant insulin processing. In order to produce insulin, you have to have your proinsulin cleaved into insulin and C-peptide. So if you look at the panel that shows the red arrow and the green arrow, this is what usually happens. You have the proinsulin in red, the insulin in green in separate compartments. But if you have a problem in this process of proinsulin processing, you have these two molecules in the same place. So this is what we call aberrant insulin processing, and that's why this kind of differences gave rise to the suggested endotypes. That is, these are only two suggestions. There are many other suggestions. Type 1, endotype type 1, and endotype type 2, where one affects younger age group, one has an aggressive insulitis with more C and B cells, T and B cells. Beta cell destruction is much faster. Proinsulin processing is abnormal, which makes the proinsulin to C-peptide ratio is high, and the rate of progression, as I mentioned, is typically faster. And I'll just skip this. Now, why is this important? Because if this means that there are different mechanistic pathways that is causing different cells involved in different times, it means that I can interfere differently according to the patient. Okay, so treatment and prevention is different. But the question remains, which factor contributes to which, in whom, and at which stage? So I need to know, if I'm thinking of this endotype, how can I have certain biomarkers in the blood? I cannot go and do tissue biopsy for everyone who is diagnosed with type 1. I need biomarkers to tell me that this is the endotype you are thinking of, and what is the better treatment for that endotype. This is not to go through. These are all cells that are involved in the autoimmune process. And all the boxes that you see until 11 are immune modulating therapies that have been or thinked of to be used in modulating whether it's prevention or treatment of type 1 diabetes, according to the step of the autoimmune process. And these drugs have been used. If you can see, this is the same ribbon for the stages of type 1 diabetes. There were many trials to try to prevent or treat type 1 diabetes, and many of these trials did not meet the end point that they were needed to. But I will give you one example. Rituximab, which is an anti-CD20 it works against the B cells. Okay? So if you use it for an older age type 1 diabetes, who has no B cells in his pathophysiology, as I mentioned, they have more of a T cell. So if you use it to the wrong person, it will not work. So knowing these kind of etiopathological pathway will redesign the way that we use these medications in trials, so that we choose the candidate patient that will respond to this treatment. The only medication now that is approved for delaying the onset of type 1 diabetes is teplizumab, which is an anti-CD3 medication that showed that it works well with young age groups because it's an anti-CD3, because these are the young patients who have T-cell involvement highly. So what do we have to do now? We have first to look at what kind of phenotype our patient is, then at what stage of presentation did we catch this patient? Can I stratify this patient and enroll these patients into predicted responder trials? And then can I measure the biomarkers? And finally, can I use a certain medication that is appropriate for this patient? And lastly, instead of looking at type 1 diabetes as a single entity that is only treated by insulin, now it's being looked at as an end product for many other mechanistic pathways that we are now still trying to discover and see what biomarkers are there for that pathophysiology in order to use the better preventive or treatment way of treating that kind of type 1 diabetes. And I don't want you to be encouraged or discouraged, because we are still in the early stages of this kind of endotyping, and this recent article did not show any kind of subtype biomarker that we talked about very specifically, but I would add yet, because this was a small study with a small number of patients, and we will need more studies. And I think I'll stop now.